The aesthetics industry is hitting a ceiling. As injectables become more commoditized and price wars drive margins down, the most successful practices are no longer just treating wrinkles. They are treating the entire lifespan of the patient. Welcome back to the Business of Aesthetics podcast. I'm your host, Don Adeesha. To help us navigate the massive shift towards integrated wellness, we are joined by Dr. Charles Mock. Dr. Mock is the founder of Allure Medical. After a career running an emergency department, he transitioned into private practice to focus entirely on preventing the emergencies he used to treat. Now, he has built a massive multi-state footprint that seamlessly blends traditional cosmetic injectables with high-retention medical services. Today, we are going to discuss the financial realities of female HRTs. We are going to talk about monetizing non-surgical weight loss and how to seamlessly cross-sell Wayne Health with your injectable business. This episode is brought to you by Equimarketing, the digital growth partner behind this podcast and a trusted resource for aesthetic practices looking to dominate their local markets. That being said, Dr. Mock, welcome to the show.
Thank you.
Dr. Mock, the traditional aesthetic model relies heavily on constant churn of injectable appointments. As those services become more commoditized, how does pivoting your operational focus towards preventative wellness actually insulate a practice's cash flow from local price wars?
Yeah, great question. So I see the injectable patient is this kind of a filter for people who love themselves more than their possessions. And I think about our typical patient, our average patient, is a 47-and-a-half-year-old woman. We're about 97% women in our practice. And, plus or minus 20 years, but 47 and a half is the average age of somebody entering our practice. And they're looking to look and feel better with less risk. That's really the fundamental avatar for our patient. And when we look at as industries shift, the biggest industry in the future is going to be the longevity industry. And that's going to be something about being able to look better, not only on the outside, but look better on the inside. And this is really a key focus. The problem is that it is very hard to attract people for wellness because the insurance industry has dominated people's mindsets about what they should and should not do. So in other words, if insurance doesn't cover it, I ought not do it, even though there's a lot of options for people to live longer, healthier lives through both their insurance, say, benefits, but through non-insurance things. So we continue to use the platform of bringing people in for toxins and fillers. And then we convert them into a membership model with our toxins and fillers, which includes some energy-based services and discounts on skincare. And once they're with us for a year or two, then they'll start venturing into other services that potentially can expand their health span. And I think about this in terms of what are we trying to accomplish with wellness? We're trying to get people to live longer, healthier lives. We think about lifespan. That's how many years you're on this planet. And health span is how many years you're on this planet without being sick with major issues such as stroke, heart attack, Alzheimer's. And when somebody adds 2 or 3 years of lifespan, they get a little bit more health span. They might get 3 or 4 years of health span. And we look at different things that have a meaningful impact on people's lifespan and health span, managing your blood pressure, managing your blood sugar, things that you do routinely. Look, screening for some cancer, there's some cancer screening that's available. But then there's a lot of things that health insurance does not cover that can meaningfully expand your lifespan. And a good example is in the Affordable Health Care Act in 2010 and 11, Congress mandated that insurance companies pay for screening for certain cancers. There's 50 or 70 screening tests that are covered, depending on the circumstances, pap smears, mammograms, colonoscopies. And even with that only picks up about 1 out of 4 cancers potentially. Yet we have no screening for heart disease, no screening for the rest of the cancers through our health insurance, but there's actually options for people to screen for those things. When you pick it up early, heart disease before it happens, neurocognitive decline before it happens, cancer when it's the size of a peanut, you can meaningfully extend your health span. And then there's major medical conditions that we treat that really can be impacted on other things that you do to expand the period that you're mobile, that you're energetic, that you have a good body composition. And I really see the patient that's coming in for cosmetic. A lot of my peers think that we're treating a bunch of vain people, vain rich people. But in reality, our customers come right across the economic spectrum. They've got to be able to afford what they're doing, but they come across the economic spectrum. And they're not vain. That's very rare that we see the kind of the people that look overdone. These are just people that they look in the mirror like, gosh, I don't feel like the woman I'm seeing. I look very tired, look sad. I want to project an image that matches what I feel on the inside. So they come in to see us to get something done. In fact, they use the word Botox or filler just as a word to say, I want to do something. I don't know exactly what I want, but I want to look a little bit better to match how I feel on the inside. And those very same people will be open to the idea of screening for heart disease, of considering optimizing their hormones, of looking at regenerative services, about improving their circulation, improving their energy, improving their weight and their body composition. So really for us, this is just a doorway into wellness. And our passion is not about cosmetic. It has always been about health span and lifespan. Really, our company's goal is to add 250,000 years of health span to our community. Optimally prepared to handle this. So I had wanted, this is years ago, but she wanted to no longer have menstrual periods. It had nothing to do with wellness, but she didn't want to have menstrual periods. She had no symptoms at all, and she wanted to get an endometrial ablation. This is in the early days of endometrial ablation. So she went to gynecologists. They said, well, I'll just document that you're having severe untractable bleeding. We'll bill your insurance. She goes, well, no, I don't want to do insurance fraud. I'll just pay for it. Not one of the doctors she saw was willing to take cash, self-pay. Okay. In fact, they told her she couldn't get it done unless she said she had symptoms, which she didn't have. And I think this is how most healthcare is. They don't have a method for letting people pay for optimal healthcare. My brother-in-law, I had him do a screening test of his heart, and he's 53, he had advanced heart disease, and he saw his cardiologist. He said, well, you can't go on the proper drug because your insurance won't cover it. I said, Tim, you can just pay for it. It's not that expensive. He goes, no, he said, I can't have it because I don't meet the insurance qualifications. So this is really what the general population is faced with when they see their primary care doctor or their specialists, is they're being told what their insurance will pay for. And the doctors interpret that as, this is the only thing you can do. And I've seen that same bias appear in my patients. They say, well, my doctor says I can't do that because it's not covered. In other words, insurance companies dictate your health. And keep in mind, insurance was not designed to keep you healthy. It was more designed like car insurance, a house insurance. Your house burns down, your insurance covers it, but it's not paying for the smoke detector, not paying for new filters in your furnace. So I think we can start changing our relationship with healthcare and with our insurance companies who's paying for it if we want to optimize our health, just like they're not paying for you going to the gym or taking care of yourself or eating healthy. So I think the cosmetic patients select out the people who are going to want to, out of their own personal pocket, pay for things that are make them healthier and live longer. Whereas the general population, if it's not quote unquote free, they're okay with dying because their mindset, and it's not like they want to die, but their mindset is, if it's not covered by my insurance, I ought not do it. They know better than I do about my health.
An incredible opener there, Dr. Mock. A lot of things to really deconstruct. But before we move on, I really want you to make the distinguishment between lifespan and health span.
Okay, great one. So health span is generally referred to as a time that you live where you do not have major disease or disability. So let's take somebody who lived to 103 years old. They had a very long lifespan. They probably had a very long health span too. Most likely that person, until they were 102, was mobile. And they were maybe not running up the stairs, but they were getting in and out of the car, being driven around, having relationships with family. They weren't laying in a nursing home for 5 years. And somebody that dies in their 70s typically had a few years where they were disabled in some way. They might have had a stroke, might have had premature Alzheimer's, might have had heart failure. So health span is the number of years you live without being sick. Not totally normal, like the 100-year-old example, but without being sick, where you can really still enjoy life and lifespan. So we see, like, I give you an example, is that right now there's a big talk about hormone replacement therapy. And the biggest disservice to women's health in the past 100 years was this WHI trial where the FDA misled women to thinking that estrogen caused breast cancer. And of course, they've reversed that November 10th of last year. But if a woman goes on a non-oral or topical or pellet estrogen and progesterone, she just goes on those two things, she likely adds 2.5 years of lifespan, but about 3.5 years of health span.
Okay.
For something that really you can buy on Amazon Pharmacy for $100 a month. And whether or not your insurance covers it. So I think that this is how we should think about health span, is that that's kind of more critical, because if you expand your health span, your period of illness before you die actually shrinks.
Right. So your quality of life overall increases.
The duration of quality of life, yes. Yeah, so just to put it in numbers, if you, let's say one person lives to 80 and at 75 they have Alzheimer's and they decline over 5 years, they have 75 years of health span. And somebody else lives to 80 and they're fine until 79.5 and they fall and break their hip and die, that's 79.5 years of health span. That was a better life.
Now, Dr. Mock, for the practice owner looking to integrate this, which is female HRTs, what is the exact operational roadmap to add HRTs without diluting the high-end cosmetic brand that they've already built?
So I don't really think that this dilutes it at all. I think it just augments it. In our practice, we use primarily pellets. I've gone through a lot of transitions. So I've been in business since Botox was FDA approved, well before the hyaluronic acids were approved, well before they were even approved. And right when the Women's Health Initiative trial more or less outlawed the use of HRT. They didn't really outlaw it, but they put a black box, which is one step short of outlawing it. And we started doing hormone replacement back then because I read the studies. I realized this was completely misrepresented. And at the time we were using topicals, and it was kind of politically incorrect to use some of the pharmaceutical products at that time. So we used topical hormone replacement. And then we changed over to pellets, which are more effective, especially for testosterone. But anyways, in our pellet practice, women come in about every 3 or 4 months to get their pellets. And this is testosterone and estrogen. They take progesterone orally. And that synchronizes really with their injectables. And they stay with us longer than injectable-only patients. So when you look at what causes retention in an injectable practice, and this is a mixture of my personal experience, but mostly looking at industry standards. Number one is size of sale. The more somebody spends per visit on their injectables, not like the higher price per unit, but the more stuff they get done, the more retention you have. Rebooking the patient after they leave, getting them on skincare, doing some energy-based services, putting them in a membership, and then converting them to other services in your practice. All those things increase the longevity of your practice. And, this being somewhat of a podcast sponsored by marketing, you're paying for a customer to come in your office, most cases hundreds of dollars. And to recoup that, you want them to stay with you for a few years. And having something besides just injectables or cosmetic stuff is a good way to look at how do we retain these patients for a longer period of time and help them look and feel better, both on the inside and the outside. So I think it's augmenting, not shifting. Now, I know some, there's practices that do pure HRT, that do pure cosmetics, some that blend it. In our practice, we do not market for wellness at all. We simply internally market it to our existing cosmetic base.
Amazing. So what is the exact operational roadmap to add HRTs onto the already brand that they got going on?
Yeah, so we've been doing this for over 20 years. So patients know that we offer. I've written books on hormones for men and women. So when the patients come in as a cosmetic patient, part of the get to know us is I've written 9 books, and based on the patients where they're at in their life, the staff gives them one of the books that's appropriate for them. And if it's a woman in menopause, it's going to be the book on women's health and hormone replacement therapy. And this is a gift we give the patient. And then we're not talking about this much on their first visit, but after they're here with us for a few visits, we'll realize that they're probably in perimenopause or menopausal age. And the provider will just say, "Are you in menopause? Are you in perimenopause?" "Yes." "Well, let me tell you about our program." And they explain it to them, give the patient an option. And a high percentage of patients, flip into that service on that day, if they're medically appropriate. So it is something that people can directly market for. We really haven't We found that the cost of marketing for an HRT patient is about the same as cost of marketing for a toxin patient. And the toxin patient is typically an HRT patient in our business anyways. And I know some people have a younger demographic, but not us. We have a little bit more mature practice. So we're capturing those people. And the real thing is too, is this is an evolution over 20 years. Now we know that the earlier a woman starts on hormone replacement therapy in the perimenopause or menopause stage, the more health benefits she gets long-term. So Alzheimer's is reduced even more so if estrogen is started before menopause is completed. So that's the targeting, and our average patient is 47 and a half years old.
Amazing. Dr. Mock, we are seeing a massive gold rush with non-surgical weight loss, but many clinics are treating it as a cheap transactional side hustle. What is the specific clinical workflow required to take a transient weight loss patient and seamlessly convert them into a high-ticket, lifelong aesthetic patient?
Yeah, that's a great question. I'd say for the most part, we have two different arms of our weight loss patients with the GLP drugs. One is people that are coming in just for that. And the other ones are patients we have a very big patient base. Over the years, we've seen over 250,000 patients. So we have patients that we haven't seen in a while that we lost for whatever reason. And it actually is re-engaging them that they know they can get GLP drugs with us pretty reasonably cost. This is going to kind of go on a sideline and hopefully for public awareness, my approach to GLP drugs, because I wrote a white paper on this some time ago. We did some investigation. These drugs were designed to be something and you go on for the rest of your life. And the clinical studies showed that if somebody goes off these drugs, they gain the weight back and to some degree. And that's a concern. But if you look at the GLP drugs, the maintenance dose is 10 times higher than the initial weight loss dose, 10 times higher, because we get something called a tachyphylaxis or tolerance to the drug. But that tolerance extinguishes very rapidly when they go on a holiday from the drug. So we cycle people through these in 3-month cycles. So we put them on for 3 months. They never get to the highest dose. So they never get the major side effects. And then we take them off it for 6 to 8 weeks, start them over at the lower dose again. This substantially reduces the drug burden they're exposed to. And if you look at the side effects, major side effects in the clinical studies, right around 40, 50 weeks, people start getting major side effects. We don't let anybody get that long into it before we've cycled them out of it. So we're seeing with this is that it is constantly re-engaging the patients because they're meeting with the nurse practitioner every few months to go over their dosing. Are they adjusting it or not? And then they have an option, even like when we just talked about hormone replacement therapy earlier, there's a recent study published that women in menopause that are on GLP lose 35% more weight if they're on estrogen. So it's an opportunity to talk to your patients about estrogen. And again, those patients, in our practice, the so-called gold rush for weight loss you talked about, it's largely our existing cosmetic patients. So the patients that really are just looking to lose weight, they have a lot of options out there. And we're not really kind of honing in on them too much. We're really looking at our existing database and patients that might want other things done. We also, in our cosmetic practice, we do have surgical options too. So when people lose weight, we do bariatric surgery in one of our clinics where we do the endoscopic sleeve. We go in through the mouth and with the scope and sew the stomach shut. We do a gastric balloon. And these actually are technically cheaper than the GLP drugs. And then we have body sculpting surgery, such as tummy tucks and breast lifts for patients that need it. We also have some non-surgical things as well. But I really see this as an adjunct because if we look at we talked about health span earlier, is that there's a meaningfully extended health span for people that go on GLP drugs that are obese, overweight, or have diabetes. So we don't really know the number of years yet. It's not clear. But it looks like about 1.8 years if somebody's on these drugs for 2 years and meaningfully changes their body composition. So these all kind of tie in together. But I would say we don't use this as a funnel into the practice so much as an adjunct to our existing patient base. We have a large patient base. And we want them to, again, feel better generally. And when patients are in the office for their whatever happens to be, cosmetic stuff, HRT, regenerative things, we can talk to them about using the GLP medications. And then we have patients that come to us just for the GLP medicines alone because they don't live nearby. Maybe they're on a telehealth platform that we don't really have other things to work with them on. Great question.
Okay. Thank you very much, Dr. Mock, and thank you very much for that comprehensive answer, really. I was just curious, do you, on your first patient visit, do you talk to them about these cycles, especially when it comes to GLPs, or is that for later time?
Yeah, great question. So we do talk to them about the cycling of it. So I wrote a white paper back when GLPs first came out, because the logic was, for the drug company, they didn't know it, but they wanted people to be on it forever. But in healthcare, we try to think about how do we get people out of disease? If somebody's got diabetes, it'd be nice to reverse that, right? So we just talked about it early on. We've got videos that explains to the patient why we like to cycle through. They really enjoy that. And we've treated a substantial number of people with this, with much better results we're seeing in the clinical studies. Maybe ours are a little bit different because they're motivated to lose weight, other than somebody saying entering into a clinical study where they're paid. But the results have been much better than expected. And the side effect profile has been just a fraction of the side effect profile we see in the studies. But we do up front tell them that this is the only option they have with us. So if somebody says, no, I just want to go on it traditionally and stay on it forever, like, well, you're not going to be our patient, because we're trying to get people healthier, not maintain disease.
Okay. That's a critical distinction right there. And I want to pause on that. And before we continue, a quick message from our sponsor, Echo Marketing. Echo Marketing are offering our listeners a complimentary 60-minute digital strategy session. This is a one-on-one consultation with the senior strategist to help you map your 12-month high-value patient acquisition roadmap. You will get a personal diagnosis of your online presence and patient funnel, uncover untapped growth levers across SEO and social, walking away with a clear, actionable plan tailored just for your practice. You can check the availability and reserve your spot in under 2 minutes at businessofesthetics.org/MSM. All right, back to our conversation, Dr. Moak. Vein health. Vein health is often viewed as an isolated, insurance-driven medical necessity, completely separate from the cash pay aesthetic environment. Now, how have you successfully bridged that gap, allowing your medical vein patients to naturally cross-pollinate into your elective cosmetic services?
Yeah, so we got into the veins before it was covered by insurance and non-surgical services. So as part of our aesthetic business was treating varicose veins that could be aesthetically displeasing. And right around 2005 and 6, some of these procedures started getting covered by insurance. So we did evolve from a pretty leg business, making legs pretty, into an ugly leg business, which was taking ugly legs and trying to make them healthier. And I was really involved with some of the first FDA studies for treating these ulcers in the leg with something called perforator vein treatment. So we've been in this for a long time. And the patients that are vein patients, they're a little bit older than our typical cosmetic patients by about a decade. A little bit more men than we have in our cosmetic business, but it's still dominated by women. But we kind of see the same thing where people get into our practice and it's mixed. We have they're in the same office as our cosmetic patients are. They're coming in a lot of times with sores on their legs or swollen legs, wearing dressings on their legs. And they start over time, because we develop a relationship with them. The relationship is they trust us. There is a series of treatments with vein disease. Typically it's somewhere between 2 and 5 sessions. And they start developing a relationship with our techs and our providers and realize we offer other things. And interestingly, back in 2012, this is a long time ago, there wasn't as many options for vein patients. I presented a paper at the American Academy of Cosmetic Surgery. Does a vein practice support a cosmetic surgery practice? And at the time, I had like 3 plastic surgeons that worked for me and a few general surgeons, vascular surgeons, different people doing different jobs in different offices. And I pretty much just did surgery on my vein patients that wanted to get a tummy tuck or a breast augmentation done. And what we saw was that in X number of dollars in vein patients, we could do 1/3 X in cosmetic surgery out of those patients. They actually converted, surprisingly, from a vein practice into a cash-paid cosmetic practice. So a lot of people in this audience, prior to taking insurance, all we do for the veins only. That's always been part of our DNA. Again, we started for cosmetic, but we turned it into a business for treating uglier legs. But those patients do convert over. And another thing, when we're talking about wellness, a big part of our practice, and I've been involved with this for a long time, is regenerative medicine. Platelets, stem cells, that sort of thing. The vein patients are a little bit more likely to be a regenerative patient than people in general. I don't know why exactly, because their insurance is paying for their veins. And it's probably because they're in our office. They know we take cash-based things. We know we do things very novel. But the patient comes in, they've got a swollen, sore leg, and we treat their venous insufficiency, and then their knee still hurts. We talk to them about other things they can do for their knee. We've been doing regenerative procedures since 2011. I was patient number one. I had a 70% subscapularis rotator cuff tear. And I was scheduled for the surgery where they shorten my biceps tendon and use that to graft the tendon itself. And I was scheduled for the surgery. And just at that time, Tiger Woods and some other athletes were getting PRP for tendons. So I bought the equipment, had my ultrasound tech go learn musculoskeletal ultrasound, and we did my subscap tendon, and it's been perfectly normal for 16 years. And then we started offering that to our patients. And then my brother was paralyzed from a spinal tumor, and I bought machinery from Korea to make stem cells out of fat tissue. We set up our own lab. This was in the days that there was no other outside labs available. We did stem cells to treat his spinal cord injury. I did intrathecal into the spinal cord. And that led to a whole regenerative practice that we've had for years. That was 2014. So those things go way back. And I'd say that's where some of the cross-pollination occurs, is that as you started getting into wellness businesses, hormones or whatever, you find other opportunities for patients that you can offer that they can't get on their own. I'd say what sets us apart as aesthetic practitioners is we have a method for letting people do stuff that their insurance says they cannot do. And it's an interesting concept. We talked about that earlier. Your family doctor will say, you cannot do this because it's not covered by insurance. No, you can do what you want to do if it's medically appropriate, and you can pay for it, obviously. But the fact that you can't pay for it doesn't mean you ought not do it. But that is a common theme. So I'll see that like a vein patient is going to be, they might do some cosmetic stuff. They might venture into that. They might do surgery. They might do regenerative treatments. They might do hormones. They might do weight loss. So we see a lot of crossover, and we call it a flip rate when they flip from one service to another. That vein patients, about 1 out of 4 of them flip into another totally unrelated service, which increases the lifetime value, because then they go into something else. We've already paid for acquisition of the vein patient, but they go to another service that really benefits the economics of the practice and, of course, the health of the patient.
Cross-pollination all across the board. And I feel like there is a common thread that I'm seeing here, Dr. Mock. Correct me if I'm wrong, but along the way, there is a lot of educating being done to the patient on their overall health, how they can increase their health span. And I think this is a point which a lot of practices that we are also seeing and have given us their questions are struggling with, is how do they educate the patient without sounding salesy? Do you have any tips for that?
Yes, and this is something to overcome. I'm sitting in an office right now, one of our offices that's got 26 patient rooms, 3 operating rooms, 4 recovery bays. It's a big office. They'll see a couple 100 people today, or at least over 100. And, we can't spend an hour with the patient trying to do a sales pitch. When you spend more than 10 minutes with them, you're actually talking them out of it. So we look at adjacent services and some degree of persuasion. So persuasion is, there's a book by Cialdini talking about how do you talk to patients about before they come in. You might send videos or maybe somehow feed them things that, based on what their interests are and their ages and their lifestyle, what their life points are. But I call it adjacent services. So the office I'm in right now is our most mature office, and we can have all kinds of services here. A HRT patient, we actually give them a little card that has sexual wellness. And it talks about vaginal rejuvenation, things are increased like the G-spot injections, that sort of thing, because it's adjacent to HRT. I'm not giving that card to a Botox patient. Now, the Botox patient comes in, and when we see she's over 47 years old, there's a possibility that she's interested in hormone replacement. So we have a very simple statement we say, and the staff says that statement. It's a 1-sentence statement just to see if there's interest. Instead of doing the consult, are you having night flashes, hot sweats, how you're sleeping? We simply just bring a 1-sentence statement. The patient says, I'm interested, then they do the consult. So these are adjacent services. If we have a vein patient, we give them a copy of my stem cell book for joints. Just give them a copy of it. And they're coming back in a few times and they can ask the technician about it. So it's really, I think, about adjacent services, because if I'll hear some consultants say, well, you need to spend 45 minutes doing the consult with the patient. I would hate it being in an environment where I got to listen to somebody talk for 45 freaking minutes about what they have to offer me versus letting the patients decide what they want to do. So I think it's the adjacent services, and really the whole goal is to get patient retention, because now you have a lot of cracks at it. So on the very first visit, they come in for, Botox or fillers. We might discuss one adjacent service. It could be skincare or membership, but that's it. We're not talking about other things because we really want to focus on close rate. And we look at the industry close rate. The patient comes in for a toxin or injectable consult. Our conversion rate into a purchase is 89%. It's very high because we have a very clean consult process, and we don't do the hour consult talking about the 100 things they might want to do, because at this point, they just want to get the heck out of the office. So keep that very narrow. And then focus on, rebook the patient, get a decent size of sale, have a good experience, and they'll come back in. Then we start bringing up other things. So, even for example, on memberships, we have a membership that's about 55% of our revenue comes from patients and memberships. So it's membership paid. We don't even offer it on the first visit because it sounds salesy. So when they come back in the second time, that's when we're going to be bringing up the membership. Hey, we can save you money by joining the membership. Whereas the first time, it sounds like a bait and switch, like we're trying to get them in something they weren't really prepared for. So I agree. We don't want to sound salesy because really, if you think about sales, there's the salesperson who thinks they're trying to sell something that people don't want. Then there's the explainer. That's the person who wants to talk for 45 minutes about how much I know about this subject. And then there's a persuader. And that's the one that listens to the patients and persuades them the proper treatment. Now, I think about my healthcare background. You said before I was in ER, I did not give the patients a lot of choice what way we were going to go. If they had appendicitis, we're going to operate on them. That's it. There's not a whole lot of other options. Now, of course, now there's a watchful waiting. It is a different world now. That's not the best example. But if somebody has pneumonia, I'm not going to say, well, these are 5 antibiotics that I'm going to potentially use. I want you to go home and research it and come back and tell me which one you think is the best option for you. Now, I'm going to say, based on current demographics and epidemiology, this is the most likely organism based on say sensitivity studies I've read recently. This is what I'm going to use. I don't even go through that discussion with them. I say, this is what I'm going to use. This is where we get it filled, and see your doctor in 3 days. And that's the persuader. I have the knowledge. When I talk to our providers that are really spending too much talking to the patient, they should be letting them know the best option. And we have a 3-step consultation process. Step 1, step 2. Step 3 is actually called shut the blank up and let the patient think. And this is very painful for providers to leave pauses and let patients think. When she's looking in the mirror, that's when you close your mouth and let them think. They're visualizing the things you just talked about. If you keep on blabbering away, what's going to happen is that the patient's going to hear you talking them out of it, and they think you want to get out of the room and do something else. So to not be salesy, don't be salesy. Listen to the patient, persuade them what's appropriate for them. You could be the salesperson trying to sell somebody something maybe they don't want. You can be an explainer and tell them everything you know about the subject, or you can listen to them and persuade them the best option.
There we go. Thank you very much for that, Dr. Mok. Now, you have scaled Allure Medical into a massive multi-state powerhouse by capitalizing on this exact preventative model. Looking 5 years into the future, what is the harsh reality facing the traditional injectables-only practice owner who refuses to adapt to comprehensive patient health?
Well, if we look at the industry trends, the number of quote-unquote med spas is growing about 22% year over year. They call it CAGR. It's been very massive growth. The filler market is actually shrinking slightly, and the toxin market is maybe growing 7 to 8%. So the number of locations is growing at a much, much faster rate and eclipsing the demand of customers. So it is going to be a matter of supply and demand creates a problem. And then what will happen, the shakeout will be, this happened before my career in 2008 and 9 when I'm based in Detroit, where the big two went bankrupt and, the market really collapsed. A lot of people went out of business. But that's the risk, is that it becomes, you're basically trying to buy patients as cheap as possible in marketing and get your toxin costs and filler costs as low as possible and do a high volume of people. And you're competing with everybody else who can do the same thing, because really to separate yourself from, if you look at how do you draw in customers? There are three strategies, and there's really not much besides these three. So number one, cheaper. Okay, that's pretty clear. Number two, better. Very hard to prove. Very hard to prove that you're better. I have some friends that really have a super narrow niche in their surgical practices, and they can prove they're better, but that is hard to do. And then different. And we're kind of on the different side where we're looking at, we have a comprehensive approach to people's health. But those are really the three things. And the cheaper one is the biggest bloodbath, because somebody else can come along and they've got private equity backing or something like that and just clobber you on the prices and drive you out of the market. So I would say that the biggest industry that ever exists in healthcare will be the longevity business. It could be the biggest industry of any industry that's ever existed. Because right now, as we're talking about this, I'm thinking about the second, third, and fourth stages of longevity, which is actually meaningfully using pharmaceuticals and other interventions to expand human lifespan in addition to health span. And we are poised to do it because we do already have a cash. We already know how to take credit cards and let people pay and make payment plans or do financing, which really isn't the case in an internal medicine practice. They're not going to offer that. Their hands are tied by what insurance has to offer. And I don't think that it's impossible for people to survive in an injectable-only practice right now, but I'd say down the road, it really is commoditized. I just look at my career there was a time when we started out, we were the only game in town. And if you wanted your Botox done, there was nothing besides Botox until like 2009. Dysport came out in 2009. But it was us or a couple other players, and that was it. And that game has totally changed. So we've separated ourselves out as we have a patented filler system where I've designed it so that fillers don't break down in your face and we can still dissolve them. That's a differentiating factor, something that's different. But there's got to be something, better, different, or cheaper. And just being cheaper and offering the same thing, that's a bloodbath. Trying to be better, that is hard to differentiate yourself in the marketplace. So I think differentiating yourself into a whole wellness. The word holistic is thrown around a lot, but this is what it is. Our patients that are coming in for Botox or filler, they really want to project the image that they feel on the inside, but they also like their organs to project what they feel like on the inside. And I think about this stages of healthcare. There's your standard healthcare, which might include some wellness things. Then there's a regenerative side, which we talked about, regenerative therapy with cells, venous disease, hormone replacement, weight loss. We have a system to reverse sleep apnea by regenerating the airway. We patented that. And after that, don't dive into anything that's totally preventable, heart disease, neurocognitive decline, and cancer. So we screen people for heart disease well in advance, a decade or 2 decades before they're going to get disease. We can screen them for cancer with special MRIs. We can screen for neurocognitive decline years before they get it. And after that is actually meaningfully using drugs that slow down the aging process, that kill off senescent or aged cells through an anti-aging regimen. And that's something that's kind of out there yet, but that is coming. The body of evidence is getting stronger and stronger every week. And I think we're in the right position to do that because the early adopters will be your Botox patients.
What an interesting conversation. Dr. Moak, thank you so much for letting it all out and holding nothing back and sharing such invaluable experience with our audience members. Is there any particular takeaway before we wrap things up that you would like to share? The golden nugget, perhaps, of this whole conversation? What would it be?
The golden nugget is the patients that you're seeing in your aesthetic practice want to look good on the inside in addition to the outside. And if you're just addressing the outside, you may have an opportunity to look at what can I do to help them look better on the inside. And these are the subjects that we talked about. These are the organs, the tissues that can be healthier in addition. Because like if you look at your patients, been with you a couple of years, they actually look younger than when they first saw you. What happens if the same could be said for their heart or their liver or their kidneys?
Dr. Moak, thank you so much for your time and sharing this incredible roadmap with our listeners today.
Thank you.
Thank you. So that was a brilliant look at the operational mechanics of building a future-proof wellness practice with Dr. Charles Moak. If you have been running a strictly cosmetic clinic and wondering how to insulate your business from economic downturns and price wars, we hope that this conversation showed you the power of the longevity pivot. Integrating services like HRT, weight loss, and weight health isn't just about adding new SKUs to your menu, it's about fundamentally increasing the lifetime value, trust, and retention of every patient who walks through your door. And as we wrap up, if you're looking for some clarity on the digital side of your practice, Echo Marketing is offering our listeners a complimentary 60-minute strategy session. It's simply a one-on-one consultation to help you map out a realistic 12-month roadmap for attracting high-value patients. You can easily grab a time that works for you at businessofesthetics.org/MSM. I'm Don Adeesha, and this has been the Business of Aesthetics podcast. Thanks for listening. Keep on leading.